I'm Sydney Baumgartner, a student in Indiana State's DIT program, and today I'm going to be talking about the clinical decision making of the ankle and the knee. First, we are going to start with the lateral ankle sprain. So, the anatomy of the lateral ankle, the important parts are the fibular shaft, the lateral malleolus, the calcaneus, the cuboid, and the fifth metatarsal, which are all bones. The muscle groups are the peroneals, which is longus brevis tertius, and the ligaments are the ATFL, the PTFL, and CFL. The common peroneal nerve runs through the ankle, and you also have the retinaculum, and it is the tibio-talar joint. The biomechanics are that the ankle is the key component of proprioception with the ground. There are different movements that the ankle is able to perform, and it has 3 different axes of rotation. The force placed on the ankle is walking, which is 5 times the body weight, and running, which is 13 times the body weight. So the ankle undergoes a lot of force when walking and running. Now, the MCL, the medial collateral ligament sprain. The anatomy is it is in the knee, so you have the femur, the tibia, the patella. The ligament involved is the MCL. The muscles of the medial knee are the vastus medialis, sartorius, and gracilis. You have the medial meniscus, and it involves the tibiofemoral joint mostly, but the patellofemoral joint can be on the medial side of the knee, just towards the middle of the knee joint more. The biomechanics of the knee is that MCL is able to withstand more force than the ACL, so it is very strong. It only has one rotational axis in the tibia, and the frontal axis is around the posterior femoral condyle. So the lateral ankle sprain and the medial collateral ligament sprain actually have a lot in common, as outlined here in the middle of the Venn diagram. So first, the ankle and the knee are both considered in literature as a hinge joint, so they are both synovial joints where 2 bones articulate. We're talking about a grade 1 ankle sprain in both of these situations. So a grade 1 sprain is considered minimal tenderness to palpation and swelling. Some of the fibers are torn, but most of them are still intact. There is minimal to no loss in function, so the patient is able to walk around normally, and there is no instability. Physiologically, there is pain, the inflammatory response is initiated, and the injured fibers can start bleeding. The MCL sprain and the ankle sprain are both considered common injuries in literature. So I would treat these both conservatively. Most of the time today, people will send the sprained ankle patients back into the game right away. I do not think this is a proper way to treat the injury. I think that people assume that since the lateral ankle is sprained, there are 2 other ligaments there that help protect the ankle. While if the MCL is sprained, there is not another ligament there to protect the knee, and it is more likely to damage the ACL. But I myself would take the patient out of play for both of these injuries and focus on conservative management. This would include functional treatment. So functional treatment has been shown to have greater stability and functional outcomes. And I would not immobilize the patient because it causes the collagen of the fibers to lay in kind of like a spider web. So they just lay in whichever way that they want. So I would focus on stressing the ligament. so the collagen fibers line up how they were before the injury. And the main goal of my treatment would be to encourage the tissue to return to the pre-injury state in the shortest amount of time possible. And I would just do this by making the patient go through minimal or pain-free movements that stress the ankle and knee joint and the MCL and lateral ankle ligaments that were injured in a way that allows that ligament to line, the fibers in the ligament to line up as they were before injury. Thank you.